Right, this is always a major task, but thank you, Janice, for excellent and very full talk, which is about behaviors of concern and mental ill health in people with Prader-Willi syndrome. And you started by discussing a little bit about the genotype-phenotype relationships and how the psychiatric or neuropsychiatric phenotype of Prader-Willi syndrome evolves with development. And you use the development of hyperphagia and the stages in the development of hyperphagia to illustrate that. And you also set out how the behaviors develop in the context of the brain maturing and how it can be similar to that of a typically developing child. But in Prader-Willi syndrome, they don't develop the coping strategies, and therefore these behaviors don't diminish with development. You also reflected, and this is an issue that you came back to several times in your talk, about anxiety, particularly anxiety about uncertainty and what is going to happen next, and the role of repetitive questioning and tantrums in that context. You described for us the 6 domains of the Prader-Willi syndrome personality, and you described and I think very nicely emphasized that these are primarily addressed through developing a personal an understanding of that person's environment, and through designing, if you like, what I think you described as a personalized environment for them. You also went on to talk about the stress sensitivity that's experienced by people with Prader-Willi syndrome, and you use the ADD to describe adaptability deficit disorder, which I think is a nice use of the term ADD, and it's about the struggles that people with Prader-Willi syndrome adapting to the changes and demands of the environment in which they live in. You went on to talk a bit more about some of the differences between the different genotypes of Prader-Willi syndrome, and also referred particularly to this issue of the sensitivity to hearing and how they might then attribute and things that they've heard in the environment and place different meanings on that. You referred to the link between the maternal uniparental disomy and psychosis, and also raised the question about dementia, which, as you say, is still, I think, very much an open question, but clearly a cause for concern, given that we have increasing numbers of people with Prader-Willi syndrome in a very positive way living into later life. You talked about the importance of stress and conflicts with the environment, and then went on in detail to talk about the diagnostic interview, the mental state examination. And you, I think, used a very nice phrase as the environment as the shadow patient. So you really, your diagnostic interview isn't just about the person with Prader-Willi syndrome, it's about the environment. And Christian, you emphasized this, it's also about understanding the family and other people in that person's environment. And in the case formulation, you talked about predisposing, precipitating, perpetuating and protecting factors, which I think are very important. And you discussed some of the psychiatric diagnoses that have been described, from depression, bipolar disorder, psychotic illness, behavioral activation, and so on. And then you used your triangle to emphasize the different types of intervention, particularly starting with understanding and managing interactions in the environment, and then moving through, including things like coping strategies, to ultimately to the use of medication or not. And then you described some of what is really an emerging field of understanding more about the brain, neuroreceptors in the brain, but also about whether people with Prader-Willi syndrome metabolize some of the medications differently to the typically developing population. So you gave us a very robust and full description of the neuropsychiatric phenotype of Prader-Willi syndrome. And then some of the questions touched on some interesting issues between the difference between storytelling and delusions, the issues about risk, about medication again, and about residential care and repetitive behaviors, a number of things that you again addressed in some detail. I think this very nicely led to the case presentation and what in ECHO speak we call the challenge, if you like. And the challenge here, I think, Christian, was one of how do we understand the phenomena that this person presented with? And of course, which led in his case early on, at least, in the use of large numbers of medication, which clearly it sounds had no particular benefit and could only perhaps have done harm. So you described to us a 22-year-old man with Prader-Willi syndrome who had uniparental disomy and who had presented in his teenage years with temper tantrums and poor coping skills, and had started talking about Michael Jackson, and there were other phenomena that led people to believe this might be a psychotic illness. The consequence of his treatment with medication was a vastly increase in weight. So you raised the questions for us: is how do we understand such phenomena? And really in the discussion, I think very nicely, there were sort of trying to explore whether these delusions should be seen as psychosis or not, and probably not, but how one might then understand them in terms of this person's life and his loneliness. And I think, Janice, it was you raised the issue of things like using social stories. And I think, Christian, you also mentioned that he's now in a Prader-Willi specific group home and doing well in that context. So I think that challenge that you presented for us, Christian, was a very nice example about how we need to move forward to better understand how psychosis presents and when is something that may be delusional in nature, not psychosis, and the implications of that in terms of intervention. So I hope I've done justice to the two presentations.